Hi, everyone. I am Stacy Hurt, Senior Advisor at OSP, and I want to welcome all of you to our latest episode of the Healthcare Leadership Insights webinar. I also want to wish everybody happy Groundhog Day, but you can rest assured that today's webinar will be anything but Groundhog Day. I am so excited to welcome my guest today, Dr. John Whyte, who is Chief Medical Officer of WebMD. In these perilous times, we've all gone out to the internet seeking trusted information. I know for sure I have gone out to the internet to diagnose various medical conditions. I think it's fair to say that we've all done that. And we are looking for information to guide us that we can depend on. And WebMD has certainly been a consistent source of trusted information. So a little bit about John is that he focuses on developing and expanding strategic partnerships that create meaningful change around critical and timely public health issues. As we know, John is still a practicing physician in addition to his role as CMO at WebMD. And he is a writer who has worked closely to help communicate about health issues for nearly 2 decades. Today, with our focus, it's going to be about lifestyle changes. And we always, on our webinar series, talk about how digital health can help improve all of our lives and the tie-in between humanized healthcare and digital health. So we're going to talk today about the need to sort of normalize COVID. I think this is going to be something that we're going to be dealing with as we move forward. And we want to find out how digital health can help all of us deal with this new normal. Today, the episode is going to focus on patient education and how to simplify its adaptation using healthcare technology. John, how are you today? Thank you for joining us.
I'm good. It is always a delight to chat with you. So thanks for the opportunity today.
Well, I really appreciate you being with us. We have so much to unpack. I think why our discussion today is important to me is because, I'm a cancer survivor, and February starts National Cancer Prevention Month. So we're going to talk all about that. And also, I want everybody to know, our audience to know, that this Friday is World Cancer Day. And this is a day that I fully embrace. As I said, being a stage 4 survivor, it's really important to me to support everybody around the world affected by cancer. So let's go ahead and dive into it. So kicking off. So John, everybody's talking about COVID, of course. And, we recently had a new variant, Omicron. Now we're talking about a new subvariant of Omicron. But on the whole, what do you think COVID has taught us as a society? And in your eyes, what are our lessons learned from COVID?
No, I think there's a couple lessons. Some are good, some aren't so good. Part of it is we have this amazing success story of innovation. When you think about being able to bring a safe and effective vaccine to market in record period of time, that required partnerships amongst pharma, that required investment at the biggest level that we've ever seen by the government, and really the ability to conduct clinical trials around the world during a pandemic. I mean, that's a success story, as well as to bring new testing strategies, self-testing, and granted, there's been a lot of ups and downs with that. Now we're talking about therapeutics. So those all have been a success story, and it shows the determination, the scientific ingenuity, the rigor of clinical trials that can be done when there's a commitment to do it. And even what you and I talked about, there was great diversity in the clinical trials for vaccines, yet in many other areas, we don't have that. But that's because they made that commitment early on. Yeah. But the misses have been around effective communication. And that's always a challenge, I think, with the government and scientists. We've joked, everyone thinks they're a good communicator. but unfortunately they're not. And there's a skill set to it. And we've had a lot of mixed messages. We've had a lot of confusing recommendations. And I think that's hurt science. It's definitely hurt scientists who have been threatened. And it's also confused the public and has created needless suffering and pain at times because it was allowed to become a political issue rather than a scientific issue. And I think it also has shown us the vulnerabilities we have in our public health system. We've known this for a long time, that resources have not been adequately distributed to public health departments. We haven't focused on it. We don't have good surveillance systems in place. So hopefully, and I'm trying to be optimistic, I have some concerns that we are learning from the pandemic and that we're going to invest more in public health and that we're going to focus more in how we become effective communicators and address the misinformation that has existed, but then also continue our march towards greater innovation, the flexibility of clinical trials, the regulatory flexibility of federal agencies and international agencies. So honestly, Stacy, it's a mixed bag of things that we've learned, and hopefully we'll continue to improve upon these areas.
Yeah, no, I love everything you said. I always use the example of my disabled son, and when he was diagnosed in 2006. And to me, it seems like yesterday, but I'm like 2006, wow, 16 years ago. And we had,
wow, that does seem long when you phrase it that way. When you say 2006, that doesn't sound long, but when you say 16, it's like, wow.
I know. I'm still putting 2021 on checks. I gotta get with it.
Do that too.
Yeah. But I remember, continually asking all of his appointments, which, he saw like 60 different specialists. And I kept asking, there has to be an easier way to do this, to instead of loading, he's a full lift, lifting him and transporting him and go in the office. And I said, isn't there a way that we can just do this over the computer, that I can get test results over the computer? And I was repeatedly told, no, can't do that. I'm like, it's 2006. Like, we can do this. And, and I was, and of course now, that I work in digital health, and it, I know now that it was reimbursement, licensing, all these different things, but to your point, John, when we need to do something, we can do it, right? When we see what's, the urgency drives us to this innovation, we see we're fully capable of it. It's so encouraging. And
virtual health showed that in telehealth. We had payment parity, which was critical because if we didn't pay providers, they weren't going to do it. But then we also loosened, rightfully so, some of the interstate licensure requirements, as well as the tools that we needed to use. We're dialing back on some of that, sadly, in a way, but it shows, we went from 2%, in January of 2020, of, patient visits were virtual to 80% in the middle of the pandemic. And now we're down to about 20 to 30%, higher depending upon specialty. And that's where we need to think through it. What cases and what circumstances are best for a virtual visit versus, having to go in. And as we know, we have a mental health tsunami upon us. How are we going to address that through tools and resources? Because there aren't enough providers around.
Well, that's a great segue into our next topic. And especially, around mental health. You have kids, I have kids. This is such a crisis around mental health. And so, the pandemic has certainly made that so much worse. So, what is your take on where we are and where we're going in mental health? What do we need to do, John, to sort of mitigate that mental health crisis?
Stacy, I think this is the biggest health issue facing us right now and is going to continue to face us, for years. We're going to get the pandemic under control. We're doing better right now. Let's recognize we're in a much better place than where we were last year. We're still going to have some bumps along the way, but I do feel we're getting to a point where there's an end game. I'm hopeful. I might be wrong, but I think that's where we're going. But we have to acknowledge that we do have, as I referenced, this mental health tsunami, that people are suffering. There's PTSD. There's a lot of depression, anxiety. I see it in the patients that come into clinic. Some are overt anxiety and depression, and others are coming in with, I'm not making this up, elevated heart rate because they've been vaping and using energy drinks, and now it's impacting their health. People are looking for ways to cope. We've seen increase in terms of suicides as well as suicide attempts, including in young people. We forget to remember that many people, hundreds of thousands of people, have lost a parent, a sibling, a loved one, a elderly grandparent. There's a lot of loss. And people often weren't able to even be there during the loss, in terms of not being able to go into hospitals. People have lost their jobs. There's, economic issues going on right now. Let's be realistic and figure out how we're going to address the challenges of mental health. And, this is something that I've learned over the years. We haven't always acknowledged it. There's no physical health without mental health. And unless we address mental health, it is going to be a healthcare crisis, even greater than what we're seeing now. And I'm just a little bit concerned that we're not focusing enough attention to it.
I couldn't agree more. We talk a lot about, going through cancer and being a patient advocate, the grief cycle, right? And where acceptance comes in. And honestly, John, I really don't even think that we're in that acceptance stage yet. There's still so much stigma around it. It's still viewed as such a weakness. I mean, when I speak to, employees across healthcare companies, and then when I get private DMs about, I feel like I can't talk about my mental health because there will be backlash on me. I don't want to hear that. It's, a mental health crisis should be as recognized as much of a disease as heart disease, diabetes, or, cancer, or the flu, or whatever. It should just be like a natural part of the conversation. Like, I'm having some difficulties and I need some help. The fact that people feel like they can't talk about it, or that it, like I said, it's going to come back on them. We shouldn't be there right now, especially with, like you said, the toll that it's taken, especially in COVID, and the ripple effect of that is going to be felt for years and years. So to that point, John, how do you think technology can help us deal with that? If, so let's say we do get to acceptance and we start to put in place some tools and some systems to help with that. What's the role of technology in that?
I'm really interested in, telehealth and telepsychiatry serve important roles, and I hope we continue to expand those. But I'm really interested in terms of throughout healthcare, but also in mental health. How do we use apps and technology? There's a lot of discussions around mindfulness apps, and I've tried a few, and I talk to patients about it, that, sometimes people think, oh, I'll just, go in a room and close the lights and, that's mindfulness. Okay, that's not mindfulness. I tell them it's like exercise. You have to practice. It takes time. It takes work. You may need a coach, virtual or real. But I think we have to think through, how do we use some of these apps in terms of helping people address anxiety? I'm particularly interested in these, machine learning and AI devices that are going to help diagnose depression, right? We have these great questionnaires, PHQ-9s, PHQ-2, that help in terms of identifying depression. But can we use technology to help identify people who are at risk? How do we use chatbots? There's a lot of discussion around that in terms of mental health disease, especially when there's limited providers. I want to make sure that we're developing, studies, whether we know these are effective or not. How do we expand upon them? How do we make sure that there's reimbursement for them as well. In the past, I think people talked about, oh, hey, does your employer give a gym membership, or do they have a corporate gym? Like, I mean, who's going to go to this now? We're not even in the office. But
I
maybe
can't.
now people are saying, you know what? I'm going to get a certain dollar amount to be able to do certain subscription apps about my mental health. Or, I'm going to look at some of these technologies that are using gaming, not necessarily pharmaceutical drugs, but are using gaming to address challenges like ADHD. So that's where I think there's exciting development on, where people are going to be able to take more control of their care. I think COVID has taught us that at the end of the day, all you have is your health, and we can do more and more in the home. Why do you have to drive to the doctor's office? Why do you have to drive to a mental health facility or hospital? What can we do at home? How do we bring more care into the home, and how do we use technology to help that? So that's what I'm excited by as we think about more use of digital tools and resources. I just think there's going to be an explosion in terms of addressing mental health issues, and we need help in that.
Well, I love what you said about the employer support. And this gets back to my point about there should not be this stigma of it in the workplace as an employee. So if we can get employers on board, like you said,
Right.
to be reinforcing their employees to focus on their mental health as well as their physical health, reward them for that, give them time to deal with that. I
Well,
think
that's
that
what we need. We need action. It's great. People are saying they should. It's okay to not be okay. That's a common, phrase line right now. But then where's the action for that? We see that in the health profession. There's a lot of burnout. But what are you doing to address that? Similar, there's still a fear that if I go complain as a pharmacist, a nurse, or a doctor, or I talk about the frustrations that I'm having, that could impact my career. That could impact my job.
right.
And that's in other fields too, right? So what are you really doing as an employer to give those safeguards, to give those resources, to give time off after perhaps a particularly difficult day? More mental health days that don't have to count as your vacation
Against you. Right.
day.
Right.
Making sure people use their PTO. How many people don't use all their vacation days a year? We should
Especially
be
the past 2
forcing, in some
years.
ways, people to take time off.
That's
Telling
right.
people don't email after 10. Between, I'm like 10, maybe it should be earlier. People are probably saying that. John, it should be 7.
Right. 10.
I'm like,
You're a
see, I email
taskmaster.
late. Okay, 7, maybe no email from 7 to 7, and make it a company policy that people don't do
Yeah.
it. So there are things that employers can do and should be doing, and not simply, have a digital sign that has a pithy quote. We need more than that, and I'm not sure we're quite there yet, Stacy. There's a lot more to do.
Well, I totally agree. And, we support each other on social media, and we're both about, action. And like you said, I mean, it's one thing to talk about it. I have this sort of thing where I said 2020 was the year of the problem. Like, we knew there was a problem. 2021 was the year of I say the prologue, which means
Yeah.
starting to talk about it. And then 2022 should be the year of the process. This is when we should be taking the steps to make the
Yeah.
changes. And the things that you mentioned, John, are such
Yeah.
easy changes to get
Yeah.
people involved with their
Yeah.
health.
I was looking in the chat, by the way, and it's a good point that people are talking about how, first of all, when you're suffering from mental health, you may not want to use certain technologies. And then depending upon where you live, you may not have access in terms of, the bandwidth, literally in terms of the internet. I mean, those are things I think that, we need to be able, to address. And just talking about them then helps raise, how do we find solutions? We have to acknowledge there's no one size fits all. It's not like we're going to solve this overnight. We're going to have to try different things. It's going to be iterative, but we can't let the perfect be the enemy of the good. And I used to hate that phrase I was younger, but I've learned to like it, because we're saying, well, we have to try certain things. We can't wait for the perfect solution, and recognize that different people, some is it is generational, is going to respond, different ways. So I think that's important to note.
Agree. My new take on that one is an imperfect something is better than a perfect nothing.
Yeah.
In other words, we got to, take
Right.
this, we got to do something. But
Mhm.
okay, we could talk forever. I'm going to shift gears a little bit to, and this is something that I have looked at time and time again that I'm hoping you can walk us through, this concept of excess deaths.
Yeah.
And deaths attributed to COVID versus the overall death rate, and assessing the true
Right.
death toll. So can you just walk us through how, that data is curated and what that.
And CDC does a lot of this work through National Health Statistics, and they put out a couple of reports because obviously there's a certain number of predictable deaths every year by coronary heart disease, by cancer, by the top leading causes. And then we know in terms of death certificates, which I acknowledge is not as good as people would think in terms of what people have died from, in terms of what's that differential in terms of what we would normally see during a year, which is somewhat predictable, believe it or not, in coronary disease and cancer, versus what we see in a particular year from, say, respiratory viruses like coronavirus. We get those daily counts, and let's be realistic, we're going to be close to 1 million, over 1 million, if not already, in this time frame. And many of those deaths, what's the exact amount, are people that didn't have to die, that wouldn't have died if they didn't get COVID. The majority of those deaths are in people that are elderly. And you may say, well, John, those people would have died anyway. That's the whole concept of what's the excess death. That's not necessarily true. And I've been asked this question a lot about, oh, aren't we over counting because anyone in the hospital is tested for COVID, as they should be. And if you came in with a broken arm and you have COVID, you're going to count as COVID, as a COVID case. That's some ways just an attempt to try to say, oh, it's only like the flu. It's not like the flu. This is a magnifold of probably 5 to 10 what flu was. And remember, there's many people, especially early on, that never came to the hospital, that died at home, that weren't accounted for. So we do know that COVID has had a huge impact on excess deaths. And that's really unfortunate, given where we are in 2022. I mean, pandemics typically do this, and I'm not even counting globally, around the world. And, people often aren't good at, assessing risk, like what's the risk of getting COVID and dying? What's the risk of getting, cancer and dying? We're more used to thinking about risks of what's my risk of getting in a car crash, which in many ways is less than the risk of getting COVID. So we have to keep that in mind as we're counting. And I've talked about this before. I'm very disappointed in the government that you'd think we'd be good counters in terms of deaths, but we're not, and we're not as accurate. But let's not, obfuscate the issue and think, oh, it's not as serious as we thought, because it really is. And there is a significant number of excess deaths that have occurred because of COVID.
Yeah. Well, speaking of, death rates and one you just mentioned, and one that we're both passionate about, obviously, is cancer. And I want to unpack a couple things here with regard to cancer and how it relates to COVID. First of all, I'm just going to throw out a broad question, and that is, how do you think that this COVID crisis, the pandemic, affected all aspects of cancer, John? So in other words, how do you think that it affected, in terms of screening, how that's going to affect things, care, just all of that? Just be interested in your
thoughts.
I
want to put this into context for folks, because, we just talked about 800,000 deaths, 1 million deaths from COVID, and how tragic that is. And it is. And thanks for Christine for pointing out as well in the chat, it's not the flu. It's definitely not the flu. So we've all put that out there. But also keep in mind, and you know this, Stacy, there's 600,000 deaths a year, every year, from cancer, every year, right? And we need to be more outraged by that. 600,000 deaths, 1 million people diagnosed every year. And what we're seeing in the data is that, especially early on, cancer delayed screenings. people did not come back, right? Because early on you were told, don't come back. And I always joke, people always find an excuse not to come for their colorectal cancer screening. I hear it a gazillion times. Was it that day? I didn't like the prep, and the prep was
That's
a
the one
little
where I really get
better.
mad because I'm a
Yeah,
colon cancer
yeah.
survivor. But go
They're always like,
ahead.
oh, I don't have a driver, because we have to have a driver, someone to drive you. So, people didn't come back. And what we're learning is that they didn't come back at all. And what's going to happen? And, I have friends that are oncologists, and they'll talk about even like head and neck surgery, where they typically would see one undiagnosed case every other week. One, off the street, comes in with a mass, never diagnosed. And for 9 months at the height of the pandemic, they didn't see any. So where were those people? It's not as if somehow cancer didn't happen.
Right.
Those people delayed care. And what we're going to see is that, it's estimated 20, 30, 40,000 excess deaths there in terms of cancer over the next few years, from delayed screenings, from missed screenings. I heard a story the other day of a colleague whose friend being screened for multiple myeloma, missed some scans during the height of the pandemic last year, had been asymptomatic, and then this year got a scan, and unfortunately it had progressed. So what would have happened if they could have gone, last year? So
Earlier.
it's going to have a huge impact on cancer diagnosis and, unfortunately, cancer mortality. So we have to encourage people to get screened. We also have to recognize most cancer you can't screen for. We're in the development of certain blood tests, but that's going to be probably a couple of years off. That's more for people that already had cancer in terms of how we effectively treat it. I mean, cancer is in many ways a success story in terms of the treatments that we have, but we still have a long way to go. And the COVID pandemic has been, an issue where it's, I think, going to cause more cancer deaths because of the delay in screening. And it's not as if, as I said, they just missed it for 6 or 9 months. They're missing it for a year, 2 years from now. And we're trying to get people to come back.
Well, that's the thing. I mean, if those screenings were missed, those people didn't come back, or they were delayed, then what you're going to see is people presenting with cancer in advanced stages.
Yeah.
And, by the time you're getting to stage 3 and 4, it's really tough to turn that around. Whereas if we could have intervened sooner,
Right.
much more treatable and beatable.
And we also have a case for the pandemic, and this was a trend beforehand, that people kind of have this fractionated care, either because they don't have insurance, they don't have, there's 30% of people don't have a primary care doctor, and those are people that are insured. Who's managing the care? You can't manage everything at a minute clinic. You can't manage everything at an urgent care clinic, and some of that's because it's uninsured, some of that's by choice. That's not adequately addressing screening. That's not talking about ways to help reduce cancer risk. It's also not helping people understand, what do these, over-the-counter, direct-to-consumer genetic tests do? The names 23andMe and others. They don't tell you about all the variants. They tell you about just a few variants for a few types of cancers. They're not get out of jail free cards that sometimes people think, oh, hey, I was negative on those tests, so I'm good. That's not the case. It's good information to know, but still, you have to think about, how are you going to manage cancer care? And it can be frustrating because we talk a lot about diabetes, right? We have a term, prediabetes. We talk about heart disease, but many doctors don't talk to patients about cancer care and focus on screenings. And, one of the persons in the chat talked about, sure, the prep isn't great, and now there's different options even, but when you think about it, this is your life. And if you are at risk, you want to have that information. And I don't know how you feel, Stacy, but sometimes I think for some patients, I've been calling it FOFO. We have FOMO, fear of missing out. There's also FOFO, fear of finding out, right? Like, I don't want to know. I've had patients say that, I don't want to know.
Well, we, a couple years ago, pre-COVID, I went to the NCCRT, the National Colorectal Cancer Roundtable, and I believe it was American Cancer Society did do a survey in terms of colorectal cancer. Why don't you get screened? And of course, the number one reason was the prep. Everybody hates the prep. But the number two reason was FOFO. And it was the fear of finding out that And I think, John, this is something that we really have to get over in this country, that people don't want to know. And just because you don't want to know doesn't mean it's not there. Wouldn't you rather know sooner and get on top of it and treat it and deal with it than, I mean, I had stage 4 cancer. Let me tell you, it sucked. I'm just going to say that. And it took everything that I had, to beat it. So I would never want anybody to go through what I went through if it was at all avoidable. Mine was not, but if somebody could be screened and deal with it sooner, I would never want anybody to go through what I did. It was hell. And so, I think that we should take advantage of all of these screenings, whether it's colorectal or mammograms or HPV, all of those, and get back on track. So that's coming from me and John. Let me go to our next question, and that is, in terms of patient education. I talked at the intro about people going out to the internet to self-diagnose and self-treat, and information is power. We're all going to do that. The internet's out there. But I want to talk about patient education and how it's crucial, to normalize this fear of the pandemic. There's been a lot of fear. There's been a lot of mistrust. How can patient education help with that? And how can digital health tools help with that?
Right. And that kind of leads to, I saw in the Q&A from Tracy, who talks about how can we in digital healthcare be the action step to help with offloading the backlog. I love your line here, Tracy. You hear a lot of people talking, but very little doing. And that is very common. And we are starting to see that where people just talk, but what we also need is action. I think what we're going to see more of in terms of patient education in a post-COVID world is more around patient centricity. And it's this buzzword that was starting to be used beforehand. I worked in an office at FDA that focused on that. But for me, what it means is the patient's going to be more in control of their care. And the focus should be on the patient. Let's be honest, the focus has always been on the doctors. Let's keep the doctors happy.
Right.
Everything is focused on the doctors. Well, we need to shift that even more and focus, how are we going to keep patients happy? What do we need to do for patients? And I think as we move more care into the home, and we've learned we can, I mean, I was impressed. We're doing, basically hospital care sometimes in people's homes. The reality is we didn't have to pay for the infrastructure of hospitals. Totally different conversation. We could do more care in the home. But I think as patients, in terms of their education, they're going to get better information. And that better information is going to lead to better health. And they're going to be in control of that. And that's where digital health comes into play in patient education. So, right, I can order some of my own lab tests from all these different vendors and check for myself. We have a whole new concept of remote patient monitoring about vital signs and other important tools. I joke, we all have on the wearable jewelry, right? We got rings, we got watches. They're giving us all this data.
Our
The future,
rings,
by the way, I think is really going to be in textiles, in our clothes and stuff like that.
Actual wearables. We talk about wearables, but actual wearables.
I got a CGM on right now, just this monitor, just because I want the data and understand how patients utilize it. But that's where I think patient education's going to be fundamentally changed. It's not going to be, oh, hey, I'm going to read a great article on WebMD, and we do have great articles on WebMD or other places, but you're going to connect that content that you're reading, and this is something we're very focused on and I'm interested in, and how are we going to connect that to care, right? So how are you going to manage that patient experience, that patient education, and you're going to stay in control of things, and you're going to manage your care. So based on what you read, you're going to be able to get a lab test and not have to leave. You're going to be able to get those imaging studies, that you need, and do it around what's convenient for you, as opposed to what's convenient for others. How do we even use more mobile, vans and mobile tools in imaging? But digital health is going to play a huge role going forward. But it's also going to be, how do we measure success, right? In the past, it was all these tools that are glitzy and cool. And there have been these apps, I won't say their names, I try them all. One of them's like, a full physical in, 30 seconds through a selfie. Like who can't,
Oh,
resist that? And then you do it, and it basically said, I'm very healthy or whatever. And I thought, okay, I have high cholesterol.
yeah.
I have high
But you
blood
couldn't
pressure.
tell
I've
me that,
calculated for it. I
right?
was like,
You
it's
missed
not
that.
right, but how could it tell? But
Right.
if I just did that app, and it's saying it's measuring my blood pressure, which I know is a continuous variable, very hard to do, then I think, ooh, I'm good. But that's not true for many people. So we have to make sure we use these tools appropriately. We're looking at outcomes of these tools. And fundamentally, I would argue, Stacy, these tools are about patient education and empowering the
Yeah.
patient,
Yeah.
and truly advancing patient centricity.
Well, yes, so many things you said. First of all, you and I, we both speak on a lot of the social
Mhm.
determinants of health and getting to the underserved. I love that idea of more mobile vans, mobile health
Mhm.
vans, getting out there, because that's how we can get to, we always talk about meeting patients where they are.
Yeah.
And, a lot of our friends in the underserved communities, they don't have access to all these digital health tools. They don't
Yeah.
have access to these wearables,
Yeah.
Apple Watches are very cost prohibitive. So,
Right.
I'd really like
But
to
we can
see,
bring down the costs of these things. It is
well,
possible to do that. I see, Craig Delarge is writing a few things. And what I would say to him, knowing his interest and your interest, is this goes to the point, and I posted this the other day on LinkedIn, we have to get more to the concept that health happens when you leave the doctor's office, right?
oh,
So
amen.
it's not helpful for me to necessarily know just your blood pressure when
Right.
you come in. It's really helpful for me to know what you're doing at home, what you're doing in terms of where your home is, what your zip code matters as much as your genetic code. And we don't think about health that way. We focus on reimbursement through the delivery of care in large practices primarily and big health systems and hospitals. Yet if we really want to improve health, it's what happens in the home. And why aren't we addressing that? And I'm not sure the doctors are the best people. They're not trained to talk about food deserts. Half of them don't even know what that is and what that means. And they don't know how to address it. But we know that's important. I love to talk about diabetes because we created a whole group of diabetes educators recognizing that physicians are not the best people to give this information and to address it. In many, smaller and rural communities, pharmacists play such a huge role in terms of working with patients on their care. But then how do we improve and enlarge the ecosystem of recognizing, as we just talked about, health is what happens when you leave. It's not about what happens just at that visit. And we don't acknowledge that. We don't incent that. We don't talk to patients about it. And that's what's fundamentally going to change health. And I think people are starting to come around to that concept.
Yeah, I couldn't agree with you more that we need to move away from episodic care,
Mm.
that the most promising opportunities with remote patient monitoring, as you said, John, are capturing what happens between the visits. And that when we talk about integrated care models, it's what happens in the home, it's what happens in the patient's environment, it's what happens in their life between the visits, and capturing all that data to ultimately improve the care plan and the outcomes and everything. So yeah, I think that we need to do a much better job of not only doing that, but helping patients understand why that's so important. And that gets
Absolutely.
back to your point. But okay, next question.
Yeah. I keep
Is
looking at the chat, sorry, and I
I
would
know.
acknowledge too, everyone's at a different point, right? Everyone doesn't want to manage their care, and it's generational, but we have to give options to people as well. And that's what we need to focus on. And I love the part, about what's happening with community workers in Costa Rica. Like we can do these things, we can train them. We're spending a lot of money in terms of building up the physical infrastructure of the health system. And is that as relevant as we go farther?
Yeah. Yeah. No, I mean, you and I have always talked about options, and I think
Mm.
options are the key. Especially in regards to telehealth, and it's
Mm.
like we're not telling everybody that you have to use them.
Yeah,
We're presenting options, and
right.
the and I've written about this too, that options give a patient hope. The more options that we have, the more hope that we have. When we run out of options, we run out of hope. And that's really what drives us in any of our care. So we saw, unfortunately, the life expectancy dropped from 78.8 years to 77.8 years, despite all of these technological advancements. And you recently commented on a report confirming those figures. So where are we heading here with life expectancy, John? Why is this happening, and what can we do?
And people might be like, oh, that's like a year. That's not that much. It is a big deal.
It's a big
and what we
deal
should
to
also
move that
point
much.
out that the life expectancy drop was bigger in people of color, in minority populations who were already slightly lower to begin with, and they had a bigger drop. And you think, how can that be? We're, America with all these technological innovations, shouldn't we be living longer? I will point out, in general, women live longer than men, so I'll just leave it at that. But it is unfortunate. We all want to have long life, but we also want high quality of life too. That's important to keep in mind. So it's a concern. We should not be having decreases. Typically what we talk about is it's stagnant, it doesn't increase. But to have a decrease is a big deal. And that's a concern. Maybe it'll just be a blip from COVID, hopefully. But I'm concerned, Stacy, back to what we originally talked about, the impact of mental health. That's going to cause significant comorbidity. Mental health and physical health are related. So it's a big concern.
Yeah. I want to go sort of off script here a little bit, and I want to get back to talking about patient centricity and patient empowerment. And I want to ask you something that probably a lot of patients want to ask doctors, and that is, how do you feel about patients who come in with all of this information, or I saw this on the internet, or I read this? I guess, number one, how do you feel about that as a practicing physician? And me as a patient advocate, what message can I take back to patients so that it's not so much adversarial as more collaborative? Because there's all this information out there, and everybody is going out and sort of willing, and it's good to have an informed patient, but we don't want it to where the patient feels like they know more than the doctor. And I guess, like I said, John, how do you feel about that? And how, as advocates, I guess, for those that are out there, I know, Christine, you're on here with us, how can we make that better for you?
Yeah. And people don't print things up anymore. I've been in practice a long time. I remember when people still used to print
the
things
reams
up
and reams of paper,
pen them in a folder and others. But personally, I like when people have looked it up. So I actually typically ask patients, even when they come in with skin lesions or other problems, I say, and they don't know my day job, and I don't tell them my day job at WebMD, I say, have you Googled it? What's your concern? Because that tells me a lot. They say they have a headache, right? And sometimes I will ask them, what have you Googled it? What do you think it is? And, sometimes people will say, I'm concerned for cancer. I had a patient many years ago who had shoulder pain, and he said to me, I've been reading up on it. I said, oh, what have you been reading? He's like, I think I might have sarcoid. Now, there's no relationship really there. And I did say to him, in a respectful way, I'm like, okay, you're not the right age, you're not the right race,
right.
not how it presents, but I'm like, I'm glad you looked it up, and let's talk about it. Why are you concerned about it? And like, this is what you're going to do. Because often I've learned over the years, patients come in because of concerns that they don't necessarily express. And to let them know it's okay to express it actually makes the visit quicker in terms of getting to why they're there. So then we can address, with the remaining time, how do we best manage it? Because that often comes later if you don't address it up front. That, I need, patients will say, like, I've had patients say, I need a total body scan, and we don't have those things. But then it's like, well, what are you concerned about? What do you think about? And I like when they looked up. 9 times out of 10 people do say they looked it up. Every now and then people will be like, no, I didn't look it up at all. But I think it goes back to the patient engagement, the patient empowerment. I think we've seen it in, COVID with a lot of misinformation, especially when I ask patients, why haven't you been vaccinated? And they'll say things to me like, I've heard this, not, they'll say things, oh, more people have died of the vaccine than have died of COVID. I'll be like, no, that's not
Absolutely not
true.
true.
Like,
Where
and
did
I
you?
just say, like, what have you been reading? And I talk to them about it. Every clinician isn't as interested as I am in those things, but that's kind of my style. And I think more clinicians are adopting that style of really engaging the patient. A lot of patients don't take their medications because they read something somewhere about a side effect or they talk to someone. So I asked them, I'm like, what have you read? Like, what's your concern? Anyone that reads the package insert, I point out, is going to be concerned. But that's, and every patient doesn't want that. Well, what I would say to folks is, and I've said this, if the doctor or other healthcare worker doesn't match your style of how you want to have a therapeutic relationship, you should find another doctor,
Find another doctor.
another
Yeah.
healthcare worker, nurse practitioner, or whatever. And my style is very much engaged. But also when people don't, people just want to defer everything to me, I'm okay with that too, but I know that up front. So I'm okay with that and I celebrate it. And I think more patients are doing that just because of the availability of search and resources out there. The challenge going forward is addressing the misinformation. And Stacy, as a cancer survivor, you'll appreciate this. About once every 3 or 4 years, and it's still happening, I see a woman with breast cancer who chose not to get chemotherapy and chose sharp cartilage. I've seen it, as I said, not every year, but every 3 or 4 years, even recently, and it's always, always a bad outcome. And they're trying to empower themselves, but they're going to places with misinformation.
Wow. It's heartbreaking and it's
Yeah.
somewhat mind-boggling, but
Yeah. I love the line Christine says in there, I'd like to ask my docs what I can do to help. I've never had anyone ask that. You should be my patient. Like that's a great thing. And I do use shared decision making. Amy's, I don't call it that because people, aren't gonna, talk about that. And everyone's at a different point in terms of, especially when you have to weigh risks of like anticoagulation and other things. But I think it's always important to talk to people about it, and depending upon their age, if they're amenable, if they have a caregiver, to talk about it as well. And then, just one other final point about the administrative burden, it really is bad. And I'll tell you, even as a physician, when I've had to have a test, I needed a CT once for an abdomen with pain, and I had an appendix rupture, and it was ordered by a doctor, and insurance is like, oh, they call me like the day before, which is, you all know is the case, and they're like, we're not going to pay for it. You need to have a KUB, an X-ray. I'm like, that's absurd. And then I'm like, I am a doctor. They don't care. And they're like, no, you're not. And I'm like, it's just, it's infuriating for everyone. And we need to have a better system about that. So I just want to point out to the person who's like, you have to like lift a Buick, Casey, it is a big issue, and we have to address that as we go forward, because where they're going to cut back on, they're going to cut back on mental health. And we already see that where there's not parity in terms of coverage, in terms of payment. And when they see increased utilization, there's going to be roadblocks. And that's what we have to be able to address.
Well, we have a really rich chat going on, audience. If it's really up and down. If you have a burning question, just please drop it in right now. And John and I are going to get to it in the last 10 minutes here. If it's further up in the chat, and John's done such a gracious job of addressing everybody's questions. But again, if you have a burning question, drop it in right now. We'll get to it. I got to talk about this.
Mm-hmm.
All right. So
very kind. You're very kind.
So, like I said, as I talked on the intro, this is National Cancer Prevention Month, and there are so many good ways to take control of your cancer risk. So as people are dropping in the questions that maybe we haven't gotten to, I want to hear a couple good takeaways get your copy today. I happen to have a signed copy from Dr. Whyte. Here it is. Which I will treasure, especially as a cancer survivor. And I always get a little emotional on these webinars, but it means a lot to me, John. But share with us maybe a couple key takeaways that everybody can relate to and everybody can do to take control of our cancer risk.
And it really is back to the point about patient education and patient empowerment and taking control of what you can control. So there is this belief that most cancer is genetic or it's just bad luck because everyone knows someone who seemed to do everything right yet still got cancer. And the reality is only about 30% of cancer is related to inherited mutations, basically our genes. And typically those cancers occur in an earlier age. About 70% of cancer is caused by lifestyle. And the good news about that is there's things that you can do, not to 100% prevent cancer, but how do you reduce your risk? And that's what I try to talk about in the book, but it has to be based on science and practical tips and tools. So we do know that diet, food really is medicine. And there's lots of data that talks about, processed foods, ultra processed foods, the consumption of red meat increases cancer risk, particularly in colon cancer. And what I talk to patients about is it's not as if you can never have a steak, you can never have a hamburger, you can never have surf and turf. The problem is people are doing it every day. 70% of Americans eat fast food at least twice a week. Only 20% of people eat fish once a week, right? 20% eat fish once a week. The rest do fish no times a week. It's not like the rest are eating more. And it's about how do you make food substitutions to consume more fish? It is about the role of exercise and physical activity. And if you think about it, who doesn't feel great after you exercise? You never say, oh, I wish I didn't go for that run. Oh, I wish I didn't go to the gym. You always feel great. It's the release of endorphins. It's the release, of the hormones. Amy, I see in here writes about the role of the microbiome. We're learning more and more about that. And that is partly dictated by the food that we're eating that impacts what's in our gut. So it certainly plays a role. But what I also talk about that we don't think about is the role of sleep and the role of stress. And there's actual data in terms of shift workers, people who work these unusual times, right? Typically at night, don't get to sleep well during the day. There's an increased incidence of hormonal cancers, primarily breast cancer and prostate in those groups. And that's because sleep, actually our circadian rhythm is cortisol, melatonin, and some other orexin and some other hormones. Certain countries actually have started to reimburse women who were shift workers that got breast cancer because we're seeing this increased incidence. So we know that sleep plays a role and we all dismiss it. We all think we'll do it later. We'll catch up on it on the weekends, and then that doesn't happen. And think about it. Who feels good after, a lousy nights of sleep? So think if you're doing that all the time, think how it's impacting your cells. And really cancer, as you know, is abnormal cell growth. It's mistakes. And that's where stress comes into play because cancer is really a disease of inflammation. And when we have stress, our cells don't function as well. And think about it. If, I told you, you need to get this report done tomorrow, and you didn't even recognize that it was due tomorrow. You thought it was, next week. You're going to make some mistakes in that. That's not going to be as good. I use the example, hey, it's like baking. If you're stressed and you usually make 20 cookies and, now all of a sudden you have to make 100, some of those cookies aren't going to turn out so well. Some of them are going to be burned. Some of them, aren't going to be shaped right. And that's the same thing in, cancer growth, that stress has that impact on how your cells divide. So it is, an issue. Someone brought up cost is an issue too. Absolutely. In terms of being able to afford, fruits and vegetables. I've had patients, and I get it. They'll say the dollar meal fills my kids, makes them full, right? And that's what they want, in their kids or et cetera. So it's a big challenge and, one, that we have to address. So the bottom line, though, is there are things that you can do. As we talked about before, your zip code matters as much as your genetic code. And these are choices that are over a lifetime. And it's the consistency of choices. So sure, all of us are going to have poor sleep on some days of the month, but it can't be several days of the week. That's going to have an impact on your health. that's going to increase your cancer risk. And that's what we have to start acknowledging. And doctors and others don't talk to people enough about it.
Sleep. Wow. So important. I love sleep myself. And it seemed like as soon as I started, I was sleep deprived from caring for my intellectually developmentally disabled
Yeah.
son. And when I took time and started getting better sleep when I got sick, that's when I started turning around. Couple closing thoughts. I see
Yeah.
two of these. So I got to hit these head on. And so many of my friends have joined: Amy, Casey, Craig, Christine, just to name a few. Thank you for joining us. People want to know, John, how do we combat this misinformation in a kind way? How do we guide people towards better information?
Yeah.
Do you have any advice on that? That's such a sticky.
Throwing that into the last 2 minutes, Stacy. Yeah, we'll just, sort that
Maybe
out.
we'll have a part two. Come back.
That is a more complicated issue, but I'll say this. Part of it is we need a little more mutual respect. So if people disagree with us on something, what do we typically do? We talk down to them. We say they're stupid. We give them ultimatums. If you don't do this, I'm not going to be your friend anymore. And we all think we're good listeners, but we're really not. We're just waiting for our turn to talk. So I do think we have to have that mindset of how do we help people become better informed? I always point this out. People who are misinformed don't think they're misinformed. They think you're misinformed. Right. So how do you reconcile that and do it in a kind, mutually respectful way? Recognize you're not going to change people's minds overnight, just as they're not going to change yours. Right. So we're not there as a society, sadly. And I think that's one of the biggest steps we have to take more.
Well, these are good points. I'm just going to wrap up here in the final minutes, just to thank you so much for coming on today. Everybody has enjoyed listening to you, and everybody, if you're not following John on Twitter, you have to do it. Please follow me too, because I get off some good lines, but please follow John on Twitter and on LinkedIn, etc. And I'm just excited, John, to shape the future with you.
Sure.
It's
Thanks for all you're doing. Thanks.
Oh.
We need more people that talk about patients, patient engagement, patient advocacy, patient centricity. So, and thanks for sharing your story. It's not easy to do. So I appreciate all that you're doing.
Thank you. That's so kind. It's just refreshing to have a physician who has your open-minded and collaborative approach to care. And that's going to be the future. More care in the community, more care in the home, empowering patients, informing patients. And like I said, it's just exciting to hear from somebody, a leader like you, to do it together with wrapped around with digital help. And I would be remiss if I didn't direct our audience. Please, if you do need healthcare solutions through technology, please contact my friends at OSP. They are willing to help at osplabs.com. And I just want to thank you, John. Any closing thoughts? We got 2 minutes left. Rapid fire. What do you want our audience to know?
No, I just appreciate the opportunity. These are dialogues that we have to continue to have. We're not going to solve these things overnight. We have to bring more civility back to the conversation and recognize we have to try different things. It's going to be iterative, but we can't ignore the immense challenges that are facing us right now. That's right.
That's right. Well, I'm going to wrap 1 minute early, whoever does that, so that everybody can run to their 1 o'clock. So anyhow, John, thank you so much again, and look forward to connecting across the e-waves.
Perfect.
Always.
Thanks, everyone. Bye-bye.
Thank you. All right. Bye-bye.